All right, we're continuing on with our newborn study. This is chapter 22, talking about newborn care. This is going to be a little bit of a repeat from things that we have previously discussed, but hopefully we can get some more information. So our slow number 5, as we're continuing on here, is we're discussing the care of the newborn, little newborn. All right. Also, while I'm thinking of it, slow number 10 and 11 and 12, we've kind of covered in previous sessions, and we'll also kind of talk a little bit more about common medications here in just a bit. So those are kind of in other places and will be in here as well. So if you have questions about that, you can let me know. Okay. So we've talked a lot about the early care of the newborn. We've talked about the importance of establishing respirations, doing the APGAR, keeping them warm, etc., etc. So now we're going to go on a little bit further with our care. And as we said earlier, the infant's liver is immature and cannot manufacture enough clotting factors. So that's why we give vitamin K injections. Because they cannot synthesize this, it helps with prevent any bleeding, and this is particularly true of an infant boy that parents might want circumcision. They have to wait at least 24 hours after birth, mostly 48, before they do the circumcision to avoid any bleeding problems. We also provide eye treatment in the event that there might be something in the vaginal birth canal to cause eye problems. And so we're going to use the erythromycin ophthalmic ointment. And then we've already talked about the cardiorespiratory status. We've talked a little bit about some of the positioning and suctioning secretions, and we're going to talk about how we keep an eye on them. Remember also that anything mama has had in labor or during even the pregnancy will affect the baby to some extent. For instance, we should know before the baby is born the GBS status of the mother. It's a good thing to know her RH factor and blood type. Any meds that were given to her in labor that might produce respiratory depression, and then if there were any problems with the labor itself, prolonged stages of something or operative delivery and so forth. So this is how we put in the ophthalmic ointment. Now this is a lot of fun sometimes, getting those little eyes to stay open and squeezing it in there, but we put a little ribbon in as closely as we can to the lower lid, and then we'll gently kind of rub it around a little bit, and it'll stick around, and it'll be evident for a while, but it will be absorbed, whatever's not in the eye itself. This is how we give injections to newborns. We use the vastus lateralis, the thigh, to give injections in. Of course, we're not going to use a huge needle, more than likely a 5/8 inch needle, probably a 25 gauge, a tiny little needle there. We're going to use the bulb suction, and so we depress it or we squeeze it down. Then we insert it in the side of the mouth, and then we let up on the suction, and it sucks out stuff, and then we expel what we removed, and if we need to do it again, we will. We'll do the mouth first, and then the nose if it's necessary. So we've talked already about how we're going to keep them warm. We're going to check those temps, especially if a baby's having trouble keeping their temp up. Sometimes I've seen nurses double wrap, double swaddle babies. Keep the cap on their head. Keep checking that temperature. If they're not dried off, do that some more. And then as things get more stable, then you might be able to, again, we'll delay the bath for 24 hours. And then at that point, if the temperature is stable, and then of course, then we may take, we're going to give the bath and we can inspect the skin a little bit more and so forth. And of course, skin to skin contact is the best thing we can do to keep them warm. Of course, this is a radiant warmer in use, and This is obviously a simulation because they don't lay the baby's head at the foot unless they are going to intubate, which hopefully we don't ever have to do. But we turn it on before the baby is born, and it's already warm when we lay the baby on it. And most of the time the baby's laid on there with their diaper. We don't keep them wrapped. And that way they can stretch out and do their thing. But the radiant warmer, this is an older model, but they're all about the same. They all are come equipped with, they plug them in, turn them on. They have suction, they have oxygen available. Oftentimes they have drawers with emergency supplies in there and so forth, and diapers and blankets and all kinds of stuff. Okay, so other care, if we need to, we feel like it's warranted, we might check the blood sugar. Remember, we do that by heel stick. Uh, Watching for those signs and symptoms, knowing about those risk factors, particularly your diabetic mother. And then we want to make sure that we watch their bilirubin, watch their jaundice, make sure they're eating well, that they're having stools, explain that this yellowing of their skin, and we don't wait for it to get the sclera to get yellow. That's a very late sign, but their little skin, they kind of have an orangish reddish cast to their skin, and when you blanch it, it will blanch white, and then the color will come back. We want to make sure that the parents understand this is something that is usually not a big issue, but we want to watch it. We want to encourage them to feed the baby, keep track of how many wet and dirty diapers they have, because the more they take in, the more stool they get rid of, the quicker the bilirubin is going to go down. And we also may have to explain to them about phototherapy, how we have to put the baby under the billy light. We protect their eyes, of course. They only wear a diaper, and lots of times they'll have a blanket rolled up around them so that it's close to them and it maintains their heat. They even have a billy blanket that they can put on the baby as well, so there's a lot of options for that. Providing skin care, typically we don't worry a whole lot about their skin. Of course, the vernix can be left on or rubbed in as lotion. I do see mamas especially like to use the baby lotion because it smells good, and that doesn't hurt them, but probably not necessary. The other thing is babies don't have to be bathed every day. They typically don't get that dirty, but we're going to wash their eyes, their face. We're going to look for the skin folds, make sure that dirt and stuff is not collecting there. We do not immerse the baby in water in the bathtub or whatever until the cord has fallen off. Making sure when we clean the diaper area, if it's just urine, we typically just take gauze sponges and warm water and clean that area. Some people like the little Huggies wipes or whatever, that's fine. Just remember when they are having stools, you've got to really watch those crevices. You can leave a stool in there if you're not careful, and then of course that can lead to skin problems and maybe diaper rash. So encourage the parents to change the diaper when it's wet right away. Change the stool diaper right away and to do proper cleaning. The cord care is usually just soap and water or even just water. Sometimes depends on your facility, and just keep it dry. Fold the diaper down. Some diapers have a little cutout on them so that you can get the air can get to the cord and it will fall off. You're always looking for any oozing or signs of infection. And also part of our job is to assist with feeding, in particular breastfeeding. I know Freeman has a lactation consultant that's there a lot. Some nurses are really good with helping mothers be successful with breastfeeding. So sometimes you might want to call a colleague in to help. And same thing with bottle feeding, how to prepare the formula, how to burp, and that sort of stuff. We'll talk about that more in just a minute. So before babies go home, we have to remove the cord clamp, and there's a special little clamp thing that we use, and you see here letter A, it's kind of inserted into the end there, and we just clip and it breaks it, and then we just remove the clamp from the umbilical stump. Okay, and you see here this baby's diaper is folded down away from the cord so it can dry. Okay. Positioning the infant is very, very important. Safe sleep. The American Academy of Pediatrics recommends that all infants be placed supine to sleep. No tummy time for a while. Overheating is not a good idea. The general rule of thumb is for moms and babies is if mama is cold, baby is probably cold. If mama is comfortable, baby's probably comfortable. If mama is too warm, baby's probably too warm. So kind of gauge it by that. If you're ever in doubt, you could always, take the temp, but a lot of people don't have a thermometer at their house, and we certainly don't want to teach anybody to do rectal temps. That is not good. Uh, They say here pacifier are used in infants over 1 month of age. Can maybe make babies more prone to SIDS. There's a lot of different thoughts on that. If the pacifier keeps the baby from screaming, I'm pretty sure a lot of people are going to use it. So again, but the back to sleep is the usual way we say it. Babies should never sleep in the bed or on the couch with adults, because a lot of babies have been rolled over and smothered by their parents in the sleep. I forget what that stands for. Plagiocephaly. Oh, that's where the back of their head is flat, and so after a while they can do some lying prone if the parents are watching each day to keep their head from getting flat on the back. In the hospital, absolutely imperative that we identify the infant with the mother. The mother and the baby at the time of birth have bands put on, and they have matching numbers. And if you take a baby out to a mother and the numbers do not match, you have the wrong infant. Sometimes the father or other support person may have a bracelet as well. And I do that at Freeman. Daddy comes sometimes and brings the baby back, or comes and gets the baby. We check the bracelets, make sure. Also, most places have some sort of a device that they put on the baby that an alarm will sound if you get too close to the door. And so that's a safety feature to prevent infant abduction. And so they leave the device on the baby until they're ready to walk out the door, and it will alarm. I think some places the door will lock and you can't get out. I don't know, but anyway, it's a safety feature, and so you may see that it's a little sensor that you get too close to the door, and it will alarm. Okay, we want to prevent infection by making sure that we teach the parents to wash their hands before they handle the baby, that they use clean technique as far as cleaning the cord and so forth, cleaning the bottles and the nipples if they're bottle feeding and so forth. Making sure that they understand that all people who handle the baby should wash their hands prior to doing so. And then they may even want them to put something over their clothing while they handle the baby. There's a picture of the baby and the mama being identified together. Circumcision is something that in some circles is very controversial. There are various reasons why parents do it. There are various reasons why parents do not do it. And so lots of times it's just done because parents don't want to have the male child go through life having to take care of the foreskin. There's all kinds of reasons, but it's usually just a personal preference. Okay, parents decide if they want the baby circumcised. Okay, let's see. Oftentimes they just don't want to do it, and that's okay. It's not our job to talk them into it or to talk them out of it. It's just, they don't want to do anything to hurt the baby, although the baby will not remember any discomfort that he has sustained, but it is kind of traumatic for some. Here are some complications. Again, it's very rare that these happen, but we have to let parents know that there are instances of complications. We do have to have a signed consent for this. That's the doctor's job. Oftentimes, some physicians will pre-medicate infants with a weight-based dose of Tylenol, and then they will take some local anesthetic gel, like lidocaine gel, squirt it on a 4x4 and put that over the end of the penis to kind of put a little local anesthetic on there. We also use non-nutritive sucrose in a pacifier for them to suck on as for quote unquote pain relief. As you see here, the baby has to be strapped down, and this is what they hate. They absolutely hate being strapped down. I don't think the procedure is bad enough, but this being strapped down and being confined is just just infuriates them. They don't like it at all. The next few slides are just how they do the procedure, and I'm not going to spend too much time on them because we don't have to worry too much about the procedure. The Gomco clamp is the one I've seen used the most. So here this is, and then the Plastabel, I've not seen that used very much, but anyway. So here's what it looks like when it's done. It's very red, very angry looking. And so the post-circumcision care consists of, there's individually packaged packets of Vaseline, just plain old Vaseline, petroleum jelly, and we get some 4x4s, and we just put a big glob of that Vaseline on those 4x4s, and we just gently kind of put it around the end of the penis, and then we bring the diaper up. And the number one thing we can do when baby's upset after this and crying is take them to mama, and mama can breastfeed or hold baby skin to skin, and this makes them feel better. The first void they may cry because it burns, and there may be some slight blood on the diaper. We do the same thing. We gently, very gently, pat it, cleaning it with plain old water and some gauze after urination, and then we reapply the Vaseline for several days, and then as it starts to get healed, we can probably let up on that, and we want to make sure that mom and daddy know how to take care of this little guy here. So neonates do have pain, and we do definitely need to assess for pain. Like I said, for the circumcision, oftentimes they'll have pre-filled nipples that look like little pacifiers that have sucrose water in them, and they suck on that, and it's kind of sweet, and it helps kind of distract from the pain. But there's all kinds of different pain scales and documents that can be used. Anyway, I'm not going to expect you to know all the components of it, but you do need to understand that we do assess neonatal pain. And as you see here, there's even one that they use commonly on the in the NICU. So we need to make sure that we assess it and that we document our assessment. So managing the non-pharmacologic, the swaddling. Babies love to be swaddled. That means we wrap them up pretty snugly and very securely. Again, the non-nutritive suckling on the pacifier, skin-to-skin contact breastfeeding, sometimes the oral glucose, although not as commonly as the others. And you can see here this little guy is pretty upset. His eyes are squinted shut, his mouth is wide open, and he's screaming bloody murder. So something, maybe he got a heel stick or something like that. It looks like she's trying to clean around his cord. Now the cord is not sore. It does not hurt them, but they just don't like it. So anyway, we do give the hepatitis B immunization to the newborn, and we start that series. Number 4, common diagnostic tests used for newborns, including the purpose of the test and nursing implications. There's certain lab and diagnostic testing that we do. It is mandated by U.S. law, some of these, and that's primarily, as you see here, getting the blood for the PKU test, looking for that metabolic inborn error for genetic issues. Okay, newborn hearing screening is mandatory in all states. And as you see here, the picture of the nurse obtaining the blood, as you see, all the circles have to be completely filled with blood or they will not accept the sample. And so they do that a lot at Freeman when we're there in the evening, and the poor little guys just scream their heads off, but they soon forget about it. But there are, and of course we check the cord blood for the RH factor and the blood type, and then anything else. But again, the U.S. law says we must do this PKU testing, and that every infant has to have a hearing screening before they are dismissed from the hospital. And if there's any unusual results with this hearing screen, then they'll reschedule it to have a repeat of something like this after they go home. Okay. Okay, this is just about hearing loss. We've already talked about the metabolic screening. All of these are done in the hospital. Okay, so this is a hearing screening in process. Okay, these are done by a tech that's trained in this. Okay, And here is a nurse has put on a little, kind of like a little hot pack. It's kind of like those kind that you buy in the store and you squeeze them and it activates and it either gets cold or gets hot. They have these for babies to increase the blood flow to their little heels so they can get a better, easier blood sample. Okay. So this is the bilirubin light or the Billy light, and you can see the baby has its eyes covered. And this one is in an isolette. They don't always put it in an isolette, but they can, or incubator, whatever you want to call it. But while I'm on this slide, let's talk a little bit about discharge teaching that we are going to include for our parents. Number one, we're going to teach them how to use the bulb syringe. Number two, we're going to talk to them about feeding positions and sleeping positions. Okay. We're going to teach them how to support the newborn's head until they get better head control. Usually by day 6, they have a little more support, but not so much. No, that's wrong. Okay, not that. Support the head until the baby has head support. Let's see. Avoid diaper rash. And by day 6, they should have 6 to 8 wet diapers in 24 hours and stools at least once in 24 hours. Breastfed babies are going to have more frequent stools. Avoid diaper rash by changing the diaper when it's wet and dirty, cleaning appropriately, and so forth. Don't submerge the baby in the bathtub until the cord is fallen off. We knew that. There's no need to bathe them daily. Clean with clean water after avoiding mild wipes after a stool. Very appropriate. We're also going to teach them the signs of, there's some more little guys with their masks on and the Billy light. We're going to teach them signs and symptoms of a sick baby. Lethargy, temperature above 37.8 Celsius, vomiting, a large projectile vomiting, this comes spewing out, okay? Green liquid stools, refusing 2 feeds in a row, refusing to eat 2 times in a row. That's not a good sign for a newborn. You better get that baby to an emergency room or urgent care or something and get this baby checked out. So those are the things we're going to teach parents. Also, in most facilities, they make the parents bring in a car seat and make sure that it's appropriate size and style, and that they know how to take it in and take it out, and how to strap the baby in it. If a baby is really small and we're really concerned about the car seat business, they'll actually come in, bring the car seat into the hospital, and we will put the baby in the car seat and monitor their O2 sat for a few hours and make sure they're safe in the car seat and not going to have any respiratory issues if they're really tiny. So car seat safety, of course, we're going to teach them never shake the baby. If the baby is inconsolable and screaming, get some help. Never shake your baby. Never strike your baby, obviously. In the crib, there should be nothing in the crib. No little bumper pads or cute little stuffed toys. It should just be bare. And again, we're going to have them lay on their back, swaddle them. Let's see, anything else I can think of? We've talked about keeping them warm and the right kind of clothing. Okay, I think that's all for this chapter.